Thank you, everyone. We're going to get started. Our next session is on meningococcal vaccines, and I'm happy to ask Dr. Paling, who is chair of the meningococcal vaccine workgroup, to provide an introduction and overview of today's session.
All right, good morning, and thank you for the opportunity to present on behalf of the meningococcal vaccine workgroup. Next slide, please. Oh, fantastic. And I want to say a very special thank you to the ACIP members, the ex officio workgroup members, and all the liaison consultants and CDC contributors, as well as our grade and ETR support. This has been a very active and had work group with lots of robust conversations from everybody. As a reminder, at the February ACIP meeting, you heard 3 presentations related to the meningococcal vaccines. The first covered the latest epidemiology of meningococcal disease in the United States. The second was by a Pfizer representative and covered the company's pentavalent vaccine clinical trial data. And the third presentation explained the workgroup's interpretation of Pfizer's trial data. Since the February ACIP meeting, the workgroup has undertaken a few activities involving the Pfizer vaccine. First, Pfizer and CDC presented their cost-effectiveness models for the pentavalent vaccine, and then the workgroup members reviewed the grade and ETR findings for the pentavalent vaccine and deliberated what to propose to ACIP. That leads us to our 2 presentations for today. First, Dr. Ortega-Sanchez will be presenting the CDC's cost-effectiveness model, and second, Dr. Crow will present the workgroup's grade and ETR assessment results. Thank you.
Thank you. Dr. Ishmael Ortega-Sanchez will be presenting next on the CDC cost-effectiveness model.
Thank you, and good morning. My name is Ismael Ortega-Sanchez. I'm a senior health economist in the National Center for Immunization and Respiratory Diseases. Today, I will talk about the cost effectiveness of a potential pentavalent meningococcal conjugate vaccine. Next slide, please. First, let me thank my collaborators at the NCIRD. Let me also mention that following the ACIP guidelines for health economic studies, this analysis is under review for its presentation for this committee. Next slide, please. The policy question under analysis is, should the pentavalent vaccine, the MEN ABCYW, be considered as an option for the meningococcal quadrivalent and the MEN-B vaccination in people currently recommended to receive both vaccines? On the left-hand side are described the current the quadrivalent and the MEN-B recommendations. We will refer to this as the standard of care, SOC. While on the right-hand side are described 4 potential strategies with either 1, 2, or 3 doses of new pentavalent vaccine in combination with the existing vaccine or standing alone. For simplicity, we label these strategies using the initials for P for a dose of pentavalent, Q for a dose of quadrivalent, and B for a MEN-B. For example, QPV refers to the vaccination strategy that uses 1 dose of quadrivalent at 11 to 12, plus 1 dose of pentavalent at 16, and 1 dose of MEN-B after the pentavalent dose. I would recommend keep this present in this notation in labels to identify the strategies during this presentation. Next slide, please. The policy question in economic terms would be, is vaccinating adolescents 11 to 16 years old with pentavalent vaccine series to prevent invasive meningococcal disease in the adolescents cost effective? As you can see, the comparator will be the standard of care, which is the current vaccination program, and I will refer to the quadrivalent as QQ, which is the 2 doses, and MEN-B vaccine for the 2 doses as VV at 16 years. And the interventions are, as you can see on the right-hand side, with a combination of the current vaccines or standing alone, QPV, PPN, QPP, and the triple P, which is the triple pentavalent vaccines. So for the base case scenario, what is the incremental cost effectiveness of vaccinating healthy adolescents 11 to 12 and at 16 years old with a pentavalent vaccine relative to using the quadrivalent or the MenB vaccines? Next slide, please. So the objective or the study question is to analyze the impact of each meningococcal vaccination strategy for the prevention of invasive meningococcal disease and the related medical care, long-term sequelae, and deaths among United States adolescents. Also to compare the health and cost impact associated with the use of pentavalent meningococcal vaccine versus current quadrivalent and MenB meningococcal vaccines, and to estimate the cost effectiveness in terms of health-related quality of life based on current available data. The perspective will be a societal perspective, and we'll attempt to quantify the life impact of cases, indirect costs in the form of productivity losses and lifetime lost earnings due to invasive meningococcal disease-related acute disease, long-term, and sequela or death. Next slide, please. To deal with key uncertainties, the decision analytical model that is proposed here is also designed with a Monte Carlo simulation. The simulations allow us to calculate not only the most likely or base case estimates for health benefits and costs, but also the ranges around these estimates. For that, we work with one hypothetical population, 4 million 11-years-old cohort. This cohort is followed for 15 years. That's the time frame, and will be explicit why we use the 15 years time frame. But benefits and vaccinations are over the age-specific life expectancy. We use a 3% discount rate for both cost and benefits. Next slide, please. For this purpose, we resort to a previously constructed decision tree to compare all strategies against no vaccination and different pentavalent strategies against standard of care. Within the decision analytical model are a disease states described in this figure. Specifically, this illustrates the way how infection will happen to a cohort of susceptibles from the top, susceptible individuals, and whether it leads to invasive meningococcal disease or not invasive. The model focuses exclusively on the IMD component of the disease states and estimates the number of cases with or without long-term disability or no sequela. The model includes notes that describe specific outcomes for survivors and for mortality associated to IMD. It also includes states for vaccination and waning of protection. Following the cohort for 15 years through the disease states allows the aggregation of these numbers and compare the associated IMD health outcomes and costs among strategies. Next slides, please. Once the core of the model is set, we fed it with diverse data and feasible assumptions. Efforts were made to include the best data available. We update data on the epidemiology of the disease, the healthcare resource utilization, the costs, the indirect costs, the vaccine characteristics, the quality of life after meningococcal disease, and other parameters. In the next slides, I will briefly describe the data components. This data, next slide, please. The previous one. First, 3 important sets of epidemiology data were used. The age, year, and the serogroup specific for B, C, Y, and W, and the incidence rates, some of them from the ABC data and some of them for other sources like the National Notifiable Disease Surveillance System, age, serogroup specific case fatality ratios, and the proportion of survivors or percent of survivors with specific sequela after disease. Next slide, please. To briefly review the epidemiological data, this slide shows marked changes in disease incidence for serogroup contained in the vaccines during the last years as available from the data from ABC, the core surveillance, and the National Notifiable Disease Surveillance System. Rates of IMD disease remain relatively higher in late adolescents, but in general, rates have been declining for all age groups. We try to disentangle what will be corresponding to the natural trend of the disease decline versus what could be the impact of the current vaccination programs. Overall, IMD incidence rates are 1/6 of those from recent pre-vaccine era. To keep the variability in the data in the model, we use a wider time range of incidence data available for the ABCs from 96 to 2020, combined with the national notifiable disease surveillance systems data. The truncation in eras was specific to when the respective serogroups vaccines were recommended, the initial ones. Next slide, please. Likewise, we fit the probability distributions to the range of case fatality rates specifically attributed to serogroups in vaccines to incorporate the variability observed in the age and serogroup specific. Data comes from, again, from the National Notifiable Disease Surveillance System from 2008 to 2020. The shaded area is for the specific case fatality rate used in the model, for the ages that are used in the model. Next slide, please. As in previous analysis, we use percents of survivor cases with specific sequela as reported in the literature. These are the percentages. The most common long-term sequela among survivors of meningococcal disease for which reliable data exists are the skin scarring, single or multiple limb amputations, hearing loss, and neurological disability. Next slide, please. The initial vaccine efficacy, differentiated by vaccine dose, and serogroup, are critical data inputs to assess the vaccination impact of individual strategies. Values and assumptions on initial protection are based on various sources, some of them coming for the phase 3 clinical trials for the pentavalent, using the non-inferiority initial vaccine efficacy by single dose and by a second dose as well. For the quadrivalent, as well as the MenB, the initial vaccine efficacy are based on some effectiveness surveillance. Next slide, please. One of the key assumptions following the initial vaccine efficacy is the one related to the duration of protection. This assumption was differentiated by serogroups containing in the vaccine. Assumptions on residual protection are based on various sources. Seroprotection is assumed to persist for 4 to 5 years for single dose of quadrivalent and the pentavalent as well, based on the serobacteria, say, from the Pfizer clinical trial report. Duration of protection for pentavalent vaccine is assumed to follow the one with the quadrivalent for each dose. Duration of protection for MenB is after fully immunized with 2 doses. The pink shaded areas denote a higher level of uncertainty of the waning assumption beyond available surveillance data or beyond available phase 3 data. Next slide, please. Vaccine costs were differentiated based on the 2023 public-private sector prices and vaccine administration settings. Ranges are estimated from public and private vaccine prices, as well as the cost of administering by setting. In the case of pentavalent, it was calculated using a hypothetical range of prices as related to the Pfizer for meningococcal pentavalent. Although not included in these cost rates and rates and cost of moderate severe adverse events were taken from the literature and included in the model. Assumptions are considered also in terms of wastage for either open vials, mishandling, or outdated shelf life. This is an assumption, 4% for all, 4.5% for all vaccines. Next slide, please. There were other benchmarks elements that were included in the decision analytical model, and you can see listed here all of them. And I will go a little bit faster. The next one, next slide, please, is about the components. Among the components of the cost of invasive meningococcal disease burden, we included one-time costs related to the acute phase of meningococcal disease and lifetime costs based on recurring charges for caring for a specific sequela. In the model, all invasive cases were hospitalized and incurring medical and indirect costs during the acute phase. Persons in the model who suffer sequela incur specific medical costs in addition to costs related to the acute meningococcal disease. Those were analyzed to come out with a specific costs. Next slide, please. Likewise, we calculated years of life lost for deaths and years of survival with sequela using appropriate age-specific United States Census estimates of average life expectancy in 2022. To estimate the economic value of life, we use the human capital approach, which assumes that the value to society of an individual's life is measured by his or her expected future productivity. Next slide, please. We accounted for decrements in quality of life among survivors of meningococcal disease with long-term sequela. Because there are limited specific measurements for meningococcal in terms of loss of quality of life that were published, we use other resources that were very close to, in terms of the etiology of the quality of life for conditions closely resembling each of the meningococcal-related long-term sequelae. Also, and this is an update in the analysis, because meningococcal disease follows a rapid clinical course, we did estimate decreasing quality of life associated with the acute illness for survivors of AMD without sequelae. That was for the first 30 days at least. Results. Next slide, please. We will see a number of results. We will see a number of results for the program impact of incremental cost effectiveness or vaccination strategies, namely health impact in terms of cases, deaths, and life years saved, also quality of life outcomes, and incremental cost effectiveness ratio, both compared to the non-vaccine and compared to the standard of care. Next slide, please. In this slide, we see the expected cumulative annual invasive meningococcal disease cases and deaths. As you can see, these are cumulative from 11 to 25 years, and the cumulative number of cases that is estimated is approximately 428 overall for the serogroups A, B, C, W, and Y, and approximately 68 deaths associated to overall for the same serogroups. Yeah? You can see the contribution of each one of the components in the standard of care, which is the in terms of the disease by serogroups. The MEM ACWY and the MEM B are the dotted lines, that both for the cases and the deaths. Next slide, please. This slide presents the cumulative number of cases saved by vaccination strategy. Out of the 428 cases in the non-vaccination scenario, you can see that overall there are a number of cases that are prevented by each one of the vaccines. Some of them overlap it completely, and you can see that the numbers are also very close, with ranges are also very overlap. Yeah? So this is one thing that I want to warn you from here on, is that because the differences are very small, it's very hard to navigate this in order to come up with which one is the cost effective, which one is not cost effective. So you fall in one or the other side of this sword because this is very thin difference. And that will be the case also not for cases, but also for the deaths. Next slide, please. Yeah, the deaths are very small numbers, and the overlap is some of them, the difference are in single digits, as you can see. And some of them overlap completely in terms of the impact of the vaccination. And on the left-hand side, you can see the notation and the labels of each one of the vaccination programs, and also the standard of care, which is in green, with the components of the standard of care, which are the quadrivalent and the MEM-B vaccination. Next slide, please. This is the number needed to vaccinate to prevent a case, save a life, of a life year, or a quality adjusted life year. And I wanted to pay attention to what will be the quadrivalent strategy, which is the first column with numbers, and the last two columns of numbers, which are basically on the same ballpark in terms of the number of needed to vaccinate in order to prevent one case, or one death, or one life year, or a quality. They are basically in the same range, yeah, and I want to warn you that the lower this ratio is, the better. Yeah? So there seems to be some case about some of the pentavalents preventing a little bit more, the society being able to vaccinate less in order to prevent one of these health outcomes. In the case of MEM-B, because it's very rare, you need higher numbers of people in order to vaccinate and prevent one of these health outcomes. Next slide, please. Now, the baseline of the standard of care can be seen compared to the non-vaccination here. In the dark shaded column, you can see what is the impact of the disease without vaccination, as estimated by the incidence data that we have, and the case fatality rates, as well as the other components. And the prevention with either the quadrivalent or the MEM-B vaccines are seen in the following columns. And the last column is sort of like summarizing all the two columns before the last one. Yeah? Those are down for not only the health outcomes, but also for the vaccination program cost and the total net cost of illness. You can see that the total cost of illness without vaccination, it amounts to only 270, this is in millions, whereas the vaccination program, because of the cost of the vaccine, it amounts to close to 2 million it cost to $2.480 billion. Next slide, please. In this one, we are seeing the health outcomes saved and the net cost per 4 million cohort of 11 years followed until 25 years. And the mean values and the 5th and 95th percentiles are presented here. So you can see that, for example, the quadrivalent, pentavalent, the strategy that is QPV has approximately 29 cases saved, 32 deaths, 775 life years saved, and more than 1,300 quality saved. And the vaccination program is in the 2,129,000,000. When making the total cost, as you can see on the last row of these lines. The first table will be very important in order to analyze, for example, what will be the policy question number 1. And the second table is making a comparison side by side of what will be the quadrivalent versus the strategy with pentavalent, and non-vaccine, which will be very relevant also to see what will be the impact in policy question number 2. Next slide, please. This one presents basically the same information that before, but specifically for the cost per quality saved by each vaccination strategy when compared to no vaccination. This will give you a hint of what's going to happen in the incremental analysis. As you can see on the left-hand side, we have the standard of care. This time we do the variability for the standard of care. Before it was only an addition of the impacts of the quadrivalent and the MenB. In this case, what we can see is that the strategy that is described by the quadrivalent, pentavalent, and V vaccine, the QPV, is a little bit cheaper in terms of cost per quality than the standard of care. But when we start increasing the number of doses, 2 doses or 3 doses, the costs start increasing, as you can see to the right in the first graph. So that will be very relevant in the comparisons, for example, of standard of care to the first strategy for the policy question number 1. On the right-hand side, we have, again, the standard of care as the first element in the graph. And you can see that the variability or the range in the standard of care is much smaller here, but it's basically the same one because we have the logarithmic scale. That's why it's ranked to be so small. But it's basically the same value, the same values in the ranges and the same values in the 5th and 95th percentile. Now, that is shown here because the standard of care is a combination of the VV program and the quadrivalent program, which is the cheapest one because we have about $500,000, a little bit more than $500,000 per quality. And this is with the updated rates and the costs that we're considering in the analysis. Now, in the right-hand side, you can see also a shaded area that will help you to understand what is going to happen regarding answering the policy question number 2, which, as you can see, that the quadrivalent seems to be much cheaper than what would be the combination of pentavalent, regarding the comparison against no vaccination. But you may guess what will be happening in the incremental analysis. Next slide, please. This slide is reproducing a little bit more with the same numbers in terms of cost per quality on the top regarding the specific cost per quality saved. But it adds also another measure, which is the cost per life year saved. As you can see, most of the times, the cost per life year saved is higher than the cost per quality. That is because in the cost per quality, we are not including only mortality, but also morbidity. At the bottom, we have 2 tables. One will also be related to the policy question number 1, which is the first column that after the labels, it comes with the strategy that makes a comparison in terms of the quadrivalent, pentavalent, and V vaccine versus the standard of care. And as we estimated, it comes as a cost saving, which means that using the quadrivalent, pentavalent, V strategy could save some money against the standard of care. Yeah? That is for both outcomes in terms of quality and in terms of life year saved, cost per life year saved. Whereas for the other extreme scenario, whereas using the 3 doses of pentavalent against the standard of care, in terms of the cost per quality, it comes costly, incrementally costly. This is in millions, so you can see that it's about 1.4 million per incremental quality against the standard of care. And in the case of life year saved, it becomes less than 0. It becomes sort of like cost saving, but that value is in the range of cost saving and costly. So it's very close to zero, but the uncertainty around that value, it lies on the left-hand side, which could be cost saving, or right-hand side, which could be costly. So that is a little bit not completely pinned down. On the right-hand side, we have what would be the answer to the incremental cost effectiveness when we use 2 pentavalent doses against the 2 quadrivalent doses. And definitely for both health measures, the cost per quality and the cost per life year saved, it comes incrementally costly. And we are talking about close to $3 million per quality, incremental for costs for quality, when comparing the 2 doses of pentavalent against the quadrivalent, the 2 doses of quadrivalent, or in terms of cost per life year saved, it goes up to $4.5 million per life year saved. Next slide, please. Now, the first question was, is it true? Is it true that it's cost saving, the first strategy, the one that we were talking about, the quadrivalent, pentavalent V? And we measure the probability following the simulation procedures. And we see that, for example, both the 5th and 95th percentiles in the simulations fall on the negative side, which means that it seems to be proven that it's cost saving. Moreover, you can see that more than 95 percentile of the iterations were negative. So it's also proven that maybe this strategy may be cost saving. So it's to the right of the vertical line that is at the 0 level. So that is one correlation, if you want, for the cost saving result. On the next slide, please. On the next slide, we have that we say that regarding the question number 2, that the 2 doses of pentavalent against the 2 doses of quadrivalent were not cost saving. In fact, it was almost $3 million per quality save, which was incrementally too expensive. And you can see that the variables that are describing this variability, and you have seen probably a number of tornado diagrams, and you understand a little bit more about what is the influence that we have in terms of the variables. And you can see that the vaccine efficacy for the first dose for the quadrivalent and most of the epi variables in terms of incidence and in terms of mortality and the rate of hearing loss and rate of neurological disability are the 10 most important influential variables, and none of them drop on the left-hand side the value of the incremental cost per quality lower than 1 million. So it is sort of like proven that it is costly from the analysis that we are presenting today. Next slide, please. The strengths and limitations. This is a complex modeling. As I said, it's very challenging to come out with a needle that tries to remain in the edge of the sword and say where it's going to fall on the other, in one side or on the other side. Explicitly use incidence and case fatality surveillance data for men BCWY vaccine containing serogroups. There are limitations, and there may be many more that you may have identified in this analysis. Data on vaccine effectiveness from pentavalent is only from clinical trials. Hard to ascertain decrease in invasive incidence rates due to natural decline trend versus vaccine-induced decline. Variability of vaccine uptake per type of vaccine is also another challenge, because that was one of the things that we needed to control. And for the conclusions, next slide, please. In the conclusions, disease rates and vaccine costs drive the incremental analysis. Although additional cases could be prevented by all vaccine strategies, they do it at different costs per health outcomes when they are compared against no vaccination. But most strategies with 1 or more doses of the pentavalent vaccine will save more or equal number of cases, but they do it at a much higher cost per quality save when compared to the standard of care. The exception, as far as we are presented here, is that the quadrivalent pentavalent V combination strategy, which includes 1 dose of men pentavalent in the substitution of the second dose of men quadrivalent and the first dose of men V, this strategy could be incrementally cost-saving relative to the standard of care. Using the last 10 years of epidemiology data and current or proposed vaccine prices will increase the cost of all the studies compared to the previous analysis. Next slide, please. I want to end this presentation and thank my collaborators who helped me put together this presentation. I'm open for your questions, I hope.
Thank you, Dr. Ortega-Sanchez. Dr. Lear.
Thank you for this presentation. Could we go back 4 slides to what you have labeled as slide 28? I'm using this as my summary slide, and I'm just going to make sure I'm understanding this carefully. So in the standard of care versus no vaccination, that's $1.4 million per QALY saved. That's in the second row, second
Yeah,
column.
that's what it is.
1.4 million.
And that's a
1,000.
combination of the MenB and the combination of the quadrivalent
Right,
programs.
so quadrivalent, BB.
BB, yes.
Then if you do QPB, we have less, which makes sense because we're replacing one quadrivalent and one B, and we're
Yeah.
getting a P. But if you go to PPP, it's going up versus no vaccination. And then in the bottom left column, we already know that QPB is cost savings versus standard of care, but PPP is incrementally costly. And the bottom right, it varies by assumptions.
It varies because we are using a different measure, health outcome, which is only mortality. If you measure by mortality only, yeah, and life years saved, yeah, and
Okay.
depending on exactly where it comes, it falls close to zero, yeah, but the ranges goes to the negative and to the positive. So it's a little bit hard to conclude something straightforward. But because you have already the cost per QALY saved that is costly, you may assume that that maybe is costly, not cost saving.
So my takeaway is that we have a current policy which is fairly, I'll say it, expensive per QALY. But if we continue with that current policy and replace a pentavalent, we'll be saving some money, and that would be both on QALY and on life year. So that's.
Well, if you introduce only one dose of pentavalent in substitution of a quadrivalent and a MenB, and the first dose of MenB, in substitution of the second dose of quadrivalent and, and the first dose of MenB. Yeah.
Correct. Okay. So thank you. That's just my summary for myself.
Dr. Talbot?
Yes, can we go to slide 11? And this actually might be more for the work group. Yeah, so see that group way to the right, the over 65 that have the highest amount of deaths? Are we going to look at the cost effectiveness and the use of this vaccine in that population? Or any of them? But it's higher than the other groups that we're talking about.
It's case fatality,
Yeah, but that's a big deal.
definitely, but
Thank you.
Yeah.
All right, I'm done.
Oh, Dr. Paling.
If we can go back to the slide that we were on for Dr. Lair, I do want to highlight, this is the result we found that was the most cost effective. We should acknowledge that the pentavalent vaccine was licensed as a 2-dose series at least 6 months apart. So we are deviating from the licensure. And I just want to make sure that is in front of everybody and we're all aware. Thank you.
Dr. Brooks, did you have your hand raised? No, okay. Dr. Cotton.
I just have one quick question. It looks as though there was a report last year on Group B meningitis vaccine possibly being protective against gonorrhea. And that's something, those are these indirect issues that you do wonder how much that would improve cost effectiveness of vaccination. Did this go into the equation at all, or has the work group discussed this? I'd just be curious what people think. This was a report by Ibarra et al., and it was from the first authors from the CDC. I can put it into the chat.
Dr. Crow?
Yes, ma'am. Thank you for the question. The vaccine you're referring to is Bexsero, which is produced by GSK and will be addressed when we assess the next vaccine, pentavalent vaccine, which is being produced also by GSK. This is the Pfizer vaccine Trememba, which doesn't have that additional benefit.
Dr. Paling?
Okay, thanks.
I really appreciate that comment because it's really important to highlight that your B vaccines cannot be interchanged. And so if you use this Pfizer pentavalent, you have to use Trumbella. And if you use the GSK, you're going to have to stick to Bexsero, and there is no mixing and matching.
Thanks a lot for that clarification.
And then implied in this, I just want to make sure I'm understanding this, because we have a shared clinical decision-making rec for B. So this is implying this turns into essentially a full recommendation.
That we will be getting to that in the next presentation, and that is an important part of the conversations that we have been having. We agree with you. Thank you.
Okay, and then specific to this presentation, my question would be, you have SOC, which presumes, again, quadrivalent and B coverage. What coverage did you assume? Can you remind us? And then also, I guess I'm wondering, because the coverage would change dramatically if you used actual coverage rates for B versus in the PPP or the QPP.
Yeah, we did both ways. We sort of like put the same coverage for all the vaccines, or we use also the specific coverage that is reported by each one of the vaccines. Now, remember that this is a decision analytical model that's static, so the impact on the ICERs is zero, because whatever you do, you save in terms of vaccination. If you have a lower coverage or lower uptake, you also lose in terms of prevention of disease. So there are no indirect effects in the estimation of the ICERs. Yeah.
Okay. Do you have an SOC that excludes B? Like, what would be the dollars?
QQ. The QQ.
QQ.
QQ. So
That is-
that's why
okay, that is
that's why
it.
I
Thank you.
disentangle both of them in order to see where is exactly the savings that are coming, or the cheapest cost per quality that is coming. And if you go to this previous slide, I believe that one, you can see that the QQ on the right-hand side, it's around $500,000 per quality.
Quadra.
Yeah. Whereas the BV, which is the 2 doses of MenB, are very expensive. It has been very expensive when we presented
Got it,
about
okay.
years ago. It grew up, in fact.
Thank you. And I guess to go back to the other slide, because the SOC is both combined, but you could also look, okay, I see. So then you have PP versus QQ. Oh, gosh, okay. The letters are sinking in. Hold on a second. So PP includes B, QQ doesn't include B, and that would be 2.9 million per
Yeah, it's
quality saved.
close to $3 million per quality incrementally save if you switch from the QQ to the PP. So it's costly to go that way.
Okay, I see. So that's PICO 1 and PICO 2. Gotcha. All right, thank you.
And the tornado diagram was supposed to see whether that was just for random result or really is costly. And the tornado diagram is focused on that specific question. I mean, you can go to the tornado diagram. Next one, this one. You see that none of the variables drop on the left-hand side. The cost per quality in the PP versus QQ to under $1 million. So it's still showing that it's costly.
Thank you. Any additional questions? Oh, Dr. Lowe?
I did have a question. Can you go back the 2 slides, the one that has the, one more?
One more.
That one. So do I understand, let's look at QQ on the right-hand side. Is that the current state of using QQ is $550,000 per quality adjusted life year saved?
Yes.
Is that correct?
Yes.
Yeah, so these vaccines are already extraordinarily expensive, and I would be opposed to adding a dime to make it a little more convenient and to increase the exposure to B because of the lack of burden of disease and cost, therefore.
Thank you. And then also, sorry, Dr. Ortega-Sanchez, could you go back to the duration of protection slide for B?
Yeah. For B, it's in slide. It's in 14. And this one, yeah, that on the right-hand side is there. And for some of my colleagues, this is in fact very optimistic scenario. For the report that we received from, for example, Pfizer, that is very pessimistic, and I can tell you that the figure is completely different in the duration of protection. This one is talking about the proportion of the initial vaccine efficacy that is observed. So you have to multiply this number by the BE, initial BE, and it will be much smaller than it appears here.
Dr. Lair?
So Dr. Crow, I just want to make sure my impression from the work group is correct, that there's at least one study out there that suggests that the percentage of effectiveness at 2 years is around 30%. Is that a fair recollection?
That's our understanding, Dr. Laura. Thank you.
Remember, this says 30, but you have to multiply that 30 by the initial vaccine efficacy, which is, I think, 88. So it's 30% of the 88% of the initial vaccine efficacy. Yeah?
So just to put it in words, basically, this is a very optimistic assumption for Men-B duration of protection, which would further increase the ICERs for Men-B.
Or the Men-B component, yes.
Thank you. And the, okay, gotcha. Yeah. Thank you.
And Dr. Paling has just helped me understand that the way that the pentavalent, is it penta or a pentavalent has been studied is it's 2 doses 6 months apart, which would not be at all the way we use ACWY vaccine, which is years apart.
Anything else? All right, well, our colleagues from Pfizer have requested to speak. So Dr. Kane, if you're on the line, as usual, we'll just request that it's 3 minutes or less. So if you'd like to go ahead and make your statement.
Absolutely, thank you, Dr. Lee. Just audio checking, can you hear me well?
Yes, we can hear you just fine, thank you.
Thank you very much. My name is Alejandro Cane. I am the US and an IDM vaccines and antiviral lead for Pfizer. First of all, I would like to thank the committee for the opportunity to speak. As you know, Pfizer has developed a pentavalent vaccine to provide the broadest protection in one vaccine against the 5 most common meningococcal serogroups causing disease, with an aim to simplify the standard of care for adolescents and young adults in the United States. The option to use a pentavalent vaccine will reduce the overall number of doses an individual will need to receive to be protected against ACWY and Men-B, and also allow simpler vaccine stocking for healthcare providers. Further, a simplified strategy will likely increase the coverage of Men-B. Pfizer would like to reiterate that recommendation proposed by the work group today for use of a single dose of pentavalent vaccine as an alternative of ACWY and B vaccines indicated to given at the same time does raise some concerns. As Dr. Paling mentioned, the Pfizer pentavalent vaccine is going to be licensed as a 2-dose vaccine. We strongly believe that 2 doses of penta vaccine should still be an option for adolescents and young adults in order to offer protection against meningococcal invasive disease. While 2 doses of Pfizer pentavalent vaccine show robust immunogenicity after robust immunogenicity, the safety and immunogenicity of Pfizer pentavalent vaccine followed by Men-B FHBP has not been studied. If the pentavalent vaccine is approved by the FDA, there will not be data on this regimen in the vaccine USPI to inform providers to be used. The use of 1 dose of Men-B FHBP after 1 dose of pentavalent vaccine will also be an off-label use of our B vaccine. As highlighted by the work group today, this proposal will also require stocking 3 different vaccines to fulfill the recommendations, which will add complexity to the implementation rather than the goal of simplifying. The proposed recommendation could actually increase inequities for individuals due to further complications of the current recommendation that this proposal may create. The current difficulties and equity associated with the shared clinical decision-making for MenB could be ameliorated by the use of pentavalent vaccine. Pfizer would also like to take this opportunity to note that there are not plans to discontinue our Trumemba vaccine if the pentavalent vaccine is approved in the US. As noted by the work group, further updated schedules that provide protection for the 5 serogroups may be supported by the extended interval of the pentavalent vaccine. Pfizer is committed to sharing the extended interval data of the pentavalent vaccine upon availability with the work group and the ACIP to support this review, but we believe that this objective could be achieved with the current data already available. Finally, we would like to thank you, the ACIP, for their tireless work and commitment to the prevention of meningococcal disease in the US. Thank you very much.
Thank you, Dr. Kane. Next, we'll move to the next presentation, which will be Dr. Sam Crow on GRADE and ETR.
Morning. So we have 4 topics to cover today. I'll begin with an overview of the policy questions and PICOs, and then we'll turn to review of each of the components of the evidence recommendations framework. After that, I'll summarize the ETR findings and end with a discussion of the work group's proposed options to the ACIP. As a reminder, the Pfizer vaccine is comprised of Trumemba and Pneumemrix. Trumemba consists of 2 purified recombinant lipidated FHBP antigens, 1 from each FHBP family, and is currently licensed and available in the U.S. Pneumemrix is a meningococcal group ACWY polysaccharide tetanus toxoid conjugate vaccine. It's not licensed in the U.S., but it's been used extensively in Europe and elsewhere for over a decade. Pfizer's clinical trials assessed the two doses at 0 and 6 months and 0 and 12 months apart. They studied the effect of the vaccine on patients aged 10 through 25 years and did so using both mini-CWY primed and naive patients. Longer interval studies are also underway, but they will not be completed before licensure or ACIP vote. As discussed in the previous ACIP meetings, the work group decided to ask and answer 3 policy questions. First, should the pentavalent vaccine be included as an option for mini-CWY MenB vaccination in people currently recommended to receive both vaccines? Second, should the pentavalent vaccine be included as an option for people currently recommended to receive mini-CWY only? And third, should the pentavalent vaccine be included as an option for people currently recommended to receive MenB only? In these 3 policy questions, the work group is basically just asking which of the quadrivalent and MenB doses can be replaced by the new pentavalent vaccine. You will see the work group had robust discussions and wrestled with each PICO question. We look forward to your feedback, comments, and suggestions on work group interpretations. Here's a combined version of the 3 policy questions and PICOs. You've seen this a few times, so I won't go through it again in detail. That said, the population is all individuals aged 10 years and older. The intervention is the Pfizer pentavalent vaccine, and the comparison varies by policy question. More on these 6 outcomes in just a moment. Before proceeding, I'd like to remind you about the routine schedule for healthy persons and populations at increased risk for invasive meningococcal disease. The schedules for the latter groups are fairly complicated, so are summarized in the final backup slide in your handouts. The routine schedule consists of 1 mini-CWY dose at 11 to 12 years and a booster at 16. 2 MenB doses are recommended at 16 to 18 years based on shared clinical decision-making. Next on the slide are the increased risk populations recommended to receive mini-CWY vaccine. Please note that these vaccines are interchangeable. I'd like to highlight the medical conditions listed here: splenia complement deficiency, complement inhibitor use, and HIV infection. People with these conditions were a focus of the work group's considerations. And at the end of the slide are the increased risk populations recommended to receive MenB vaccine. Please note that these vaccines are not interchangeable, as Dr. Paling mentioned, among the different manufacturers. Those at increased risk due to medical conditions listed here were also a particular focus of the work group. This table presents how the PICOs translate into schedule options for healthy adolescents, who are the largest but not only population that would be potentially receive the vaccine. I know we just heard a lot about this. I'm going to walk through it just to make sure it's super clear. So please note the legend at the bottom of the slide: Q equals min-ACWY, the quadrivalent vaccine; B equals min-B; P equals the pentavalent vaccine, min-ABCWY. The first two schedules listed are in the table of the current standards of care. As Ishmael said, QQ means 1 quadrivalent dose at 11 to 12 and a booster at 16. Alternatively, if an adolescent would like MinB, the schedule is QQBB, which stands for 1 quadrivalent dose at 11 to 12, 1 quadrivalent booster at 16, and 2 doses of MinB starting at 16. Now the options considered. For PICO 1, which explores whether the pentavalent vaccine can be an option for MenACWY and MinB when both are indicated, the schedule consists of, or considered was QPB, or a quadrivalent dose at 11 to 12 years, a pentavalent dose at 16 instead of a MenACWY and MinB dose, and then MinB dose is 6 months later. For PICO 2, which asks if the pentavalent vaccine can be an option for the MenACWY doses, the schedule considered as PPB, or 1 pentavalent dose at 11 to 12, 1 pentavalent dose at 16, and then 1 MinB dose 6 months later, presuming the adolescent wants to complete the MinB series. For PICO 3, which looks at making the pentavalent vaccine an option for the MinB doses, the schedule is QPP, or a quadrivalent dose at 11 to 12 and 2 pentadoses at 16. Finally, a combination of all three of these PICOs is PPP, when the pentavalent vaccine replaces all the MenACWY and MinB doses. So this is, of course, fairly complicated, so I'll return to aspects of this framework throughout the presentation. So now our first ETR topic is meningococcal disease, a problem of public health importance. Since the late 1990s, a sustained decline in the incidence of meningococcal disease has been observed in the U.S., decreasing from 1.2 to 0.09 cases per 100,000 population from 1996 to 2022. Now, that accounts for basically about 350 cases of invasive disease per year. This figure shows the incidence by age group and serogroup from 2010 to 2022. Serogroup B is shown in blue. Groups A, C, W, and Y are shown collectively in yellow. And cases of other unknown serogroup are in gray. Incidence and serogroup distribution vary by age, with the highest incidence observed in children aged less than 2 years and adults aged greater than 85 years. Peak incidence is also observed among adolescents and young adults in 16 to 25 year age range. While total cases are relatively low, even with prompt and appropriate treatment, morbidity and mortality of meningococcal disease are both high. Approximately 10 to 15% of cases are fatal. And 10 to 20% of survivors have serious long-term sequelae. These can include brain injury, limb amputation due to necrosis of the extremities, hearing loss, and reduced kidney function. So in summary, incidence of meningococcal disease is low, relatively low, and has been decreasing for some time. Nevertheless, Neisseria meningitis causes very severe disease and often leads to poor outcomes, even with treatment. The workgroup members agree that meningococcal disease is a problem of public health importance, as is shown here. Now to benefits and harms. In total, we have primary data from these 3 clinical trials taken from a variety of data sources, as shown in the far right column of the table. Of our 6 outcomes, which are listed in the left column, we do not have direct evidence for 2 of them, disease prevention and interference with other recommended vaccines. We use short-term and persistent immunity as a proxy for the former. Before jumping in, it's worth noting this is a surprisingly complicated issue. We have 4 outcomes of interest with primary evidence available to assess. We have 3 PICO questions with a number of potential schedules, and we have 2 populations that will be affected. Let's now walk through the results step by step. Here's the workgroup's grade summary table covering short-term immunity for healthy persons for all 3 PICOs. Note that the rows distinguish between the short-term immunity for MenACWY and then for MinB, shown here in the red boxes. Seroresponse was non-inferior after 1 dose of MenABCWY versus 1 dose of MenACWY. Seroresponse was also non-inferior after 2 doses of MenABCWY versus 2 doses of MinB. The workgroup did not identify any risk of bias, inconsistency, or imprecision, but did downgrade for indirectness. While HSBA titers are the established correlative of protection for serogroup C meningococcal disease, and this correlation is assumed to extend to other serogroups, direct evidence for these serogroups is limited. So there's moderate certainty for this critical outcome. And here's the summary table for short-term immunity for people at increased risk for disease for all 3 PICOs. In this instance, we're talking about those with medical conditions that put them at increased risk, not people involved in an outbreak, microbiologists, military recruits, or others who have increased risk because of certain settings or exposures. The certainty of evidence for this population is low because of indirectness due to the clinical trials not including higher risk patients, only healthy subjects. Now to persistent immunity for healthy persons. Seroprotection occurred at a similar or greater frequency between the intervention and comparisons for all 5 serogroups. The work group decided to downgrade for the certainty of evidence for MenACWY immune persistence to low because the comparisons were between 2 doses of pentavalent vaccine versus 1 dose of MenACWY. Comparisons were also staggered by 6 months. The MenB comparisons had the same number of doses and were not staggered, but relied on HSBA titers, so the certainty of evidence was moderate. For persons at increased risk, the certainty of evidence was low due to very serious indirectness, similar to short-term immunity. The slide includes the grade summary tables for serious adverse events in both healthy persons and those at increased risk. In the 2 studies, 13 serious adverse events were identified in the intervention group compared to 8 in the comparison group, but none of the intervention group SAEs were deemed related to the pentavalent vaccine by the study investigators. The certainty of evidence for both groups was downgraded for indirectness because the comparisons were between 2 doses of MenACWY versus 1 dose of MenACWY plus 2 doses of MenB. They were also downgraded for imprecision because the relative effect confidence intervals were wide. Finally, the clinical trials did not include patients at increased risk for invasive disease, so the assessment was further downgraded for indirectness. The overall certainty of evidence for healthy persons is low, and the certainty for persons at increased risk is very low. There were significantly more non-serious adverse events in the intervention group based on the results of the 2 studies. Attention deficit hyperactivity disorder, ADHD, was reported by 6 participants in the MenACWY group as newly diagnosed chronic medical conditions. 5 had an onset of ADHD-related symptoms that occurred prior to study enrollment, and the remaining participant had a history of 1 or more conditions prior to enrollment that commonly co-occur with ADHD, including anxiety, depression, and substance use. Overall, none of the NDCMCs reported were considered related to the vaccine by the investigators. No other non-serious adverse events that we are aware of were disproportionately overrepresented in the MenACWY group for many of the trials. Similar to serious adverse events, the certainty of non-serious adverse events was downgraded for both healthy individuals and those at increased risk due to indirectness and imprecision. Now to the summary questions for this section. How substantial are the desirable anticipated effects for the 3 PICOs? The workgroup members were more divided, but most thought that the desirable effects range from minimal to moderate depending on the PICO. For undesirable anticipated effects, the workgroup members thought they would be minimal to small. When asked if the desirable effects outweigh the undesirable effects, the majority of workgroup members thought that PICO 1, which covers giving the pentavalent vaccine instead of both MenACWY and MenB, favors the intervention, whereas the workgroup members are split for PICOs 2 and 3, as shown here. Now on to the next section of ETR values. Limited data are available on the values of the target population towards inclusion of the pentavalent vaccine. But in 2021, vaccination coverage of at least 1 dose was 89% for MenACWY and 31% for MenB among adolescents. Limited data are available on vaccine uptake and other individuals recommended to receive MenACWY or MenB vaccine. One important potential advantage of the pentavalent vaccine is its ability to reduce the number of doses needed for both MenACWY and MenB vaccination from 4 doses to 3. Reducing doses is a principle supported by the ACIP and the American Academy of Pediatrics, as shown here. Here's the work group's position on whether the target population feels that the desirable effects are large relative to the undesirable effects. There was some uncertainty, but the most frequent answer was probably yes. Limited data are available on how much people value the main outcomes, but vaccination rates for MNACWY are suggestive. Rates for MNB, which involve a shared clinical decision-making recommendation, are considerably lower, but the cause for this is unclear. Here's the majority opinion on whether there is important uncertainty about or variability in how much people value the main outcomes. For PICO 1, most members thought that there is probably not important uncertainty or variability. For PICOs 2 and 3, most workgroup members thought there probably was important uncertainty. Now to acceptability. Limited data are also available on the acceptance among key stakeholders of including the pentavalent vaccine as an option in the current vaccination schedule. Proponents for increasing MenB vaccination likely would be supported because the pentavalent vaccine combines MenB, which is recommended based on a shared clinical decision-making, with MenACWY, which is recommended for all adolescents. So it could increase vaccination rates against serogroup B. Patients who seek vaccination against all 5 serogroups also might be supportive due to the reduced number of doses needed, 4 versus 3. Finally, healthcare providers might be supportive, particularly if they could stock fewer meningococcal vaccines. Here's what the workgroup decided in terms of whether the intervention is acceptable to key stakeholders. For PICOs 1 and 2, the answer is yes or probably yes. For PICO 3, the workgroup was evenly split, reflecting different interpretations of the very limited data. Now to resource use. Dr. Ortego-Sanchez just presented a list, so I'll only touch on a few highlights here. Here are a few key points from the CDC model. I'd like to highlight the weighted cost per dose. Pentavalent vaccine costs more than the quadrivalent and MenB separately, but it likely would be less expensive than the two together. More on this later in the presentation. I'd also like to highlight that according to the CDC model, most MenACWY strategies would save more or the same number of cases as the standard of care, but they would do so at a higher cost per quality saved. One exception is the QPB strategy, or the quadrivalent dose at 11 to 12, pentavalent at 16, and then a MenB dose 6 months later. In terms of whether the intervention is a reasonable, efficient allocation of resources, the workgroup thought PICOs 1 and 3 would be, but thought PICO 2 would not be reasonable. Now to equity. Limited data are available on the impact of the pentavalent vaccine on health equity, but it is not expected that the vaccine will negatively impact it. The vaccine could potentially reduce disparities among those who might be interested in being vaccinated against serogroup B, but who might not receive clinical care that includes discussion of the MenB vaccine. With limited data available, the workgroup members are divided on the expected impact on health equity as shown here. Feasibility is our final ETR domain. Challenges with insurance coverage specific to the pentavalent vaccine are not expected, and neither are substantial financial burdens for providers or health systems. Pentavalent vaccine likely would be easily integrated into providers' practices. It would provide an additional vaccine option. Administration of the pentavalent vaccine is likely of equal complexity as the currently available vaccines, and barriers to stocking the pentavalent vaccine are not expected. But it is unclear whether providers are willing to stock 3 different vaccine types. Providers who routinely vaccinate persons aged 16 to 18 might have an incentive to stock the vaccine to reduce the number of doses given to patients who prefer vaccination against all 5 serogroups. Most workgroup members thought the intervention would be feasible to implement. Now to a summary of the findings. Here's where the workgroup landed in terms of PICO 1. Note that the workgroup judgments were generally supportive. Most workgroup members think the desirable consequences probably outweigh the undesirable consequences in most settings for PICO 1. The workgroup also thinks there is sufficient information to move forward with a recommendation. And here's a summary for PICO 2. The workgroup's judgments were less supportive for this PICO. For PICO 2, most of the members thought the undesirable consequences probably outweigh the desirable consequences in most settings. Most also stated that there is sufficient information to move forward with a recommendation. In the summary for PICO 3, there was more uncertainty from the workgroup here. Here are the balance of consequences for PICO 3. The workgroup members were split, but they agreed that there is sufficient information to move forward with a recommendation. Now to the proposed options. For PICO 1, which asks if the pentavalent vaccine should be included as an option for mini-CWY MenB vaccination and people currently recommended to receive both vaccines, the majority of the workgroup members propose this option. For PICO 2, which asks if the pentavalent vaccine should be included as an option for people currently recommended to receive mini-CWY only, the majority do not propose this option. Finally, for PICO 3, which asks if the pentavalent vaccine should be included as an option for people currently recommended to receive MenB only. This is the QPP schedule, or 1 quadrivalent dose at 11 to 12 and 2 pentavalent doses at 16 years. The workgroup is divided on this option, but a small majority were in favor of not proposing it. The workgroup nevertheless agreed to have ACIP consider the strengths and weaknesses of this option. Returning to the slide I presented earlier, here's where the workgroup landed in terms of the schedule options. Of the 4 options considered, the workgroup would like to propose only QPB, or a quadrivalent dose at 11 to 12, pentavalent at 16, replacing the mini-CWY and MenB doses, and then a MenB dose 6 months later. The PICO 2 and combined options, or PPP, were rejected due to a substantial cost increase, very little additional benefit in terms of protecting against serogroup B for the 11 to 12-year-olds, an increased reactogenicity due to the MenB component compared with mini-CWY in the 11 to 12-year-old age group. As I just mentioned, the workgroup is divided on whether to propose the PICO 3 option, so decided to present the option's strengths and weaknesses for your consideration. More on that issue in a moment. First, I'd like to present the workgroup's suggested language reflecting their decision to accept PICO 1. The draft proposal is the following. For individuals aged 10 years and older, Pfizer's mini-ABCWY vaccine may be used as an alternative to mini-CWY and MenB vaccines only when both vaccines are indicated to be given at the same time. This draft proposal applies to healthy individuals, the routine schedule, and those at increased risk for meningococcal disease. As a reminder, this is the QPB option I presented on the previous slide. Workgroup also added 4 remarks, which are shown here. First, this draft proposal is not intended to supersede or negate the shared clinical decision-making recommendation for MenB. Second, the licensed MenB vaccines are not interchangeable. So use of the Pfizer pentavalent vaccine for the first MenB dose would require subsequent doses to be a Pfizer MenB FHBP vaccine or pentavalent Pfizer MenB FHBP containing vaccine. Third, the minimal interval for the Pfizer pentavalent vaccine is 6 months. Individuals at increased risk of meningococcal disease or for meningococcal disease who are recommended to receive additional doses of mini-CWY and MenB less than 6 months after a dose of the pentavalent meningococcal vaccine should instead receive separate mini-CWY and MenB vaccines. Finally, the workgroup plans to review the extended interval data when available in anticipation that this may provide support for updated schedules that provide protection against all 5 serogroups. The strengths of this proposal include reducing the number of doses from 4 to 3, a cost savings of approximately $95 per person for the routine schedule. The cost per quality saved is also less than the standard of care, as we heard from Dr. Ortega-Sanchez. And the fact that it's a relatively straightforward proposal for a fairly complex issue. In terms of weaknesses, the proposal does not match the dosing used in the clinical trials. It also would require stocking 3 different vaccine types, which might not be acceptable to some clinicians. Some clinics also might not have the funds available to stock multiple formulations, which could increase inequities. It could be challenging for some vaccine recipients to complete the MinB series if the provider does not carry MinB FHBP. If ACIP does not recommend the second dose of MinABCWY, insurance companies might not cover it in lieu of MinB. Finally, it potentially could increase the risk of provider vaccine administration error because so many similar products need to be stocked. Now to PICO's 3 QPP schedule, which, as a reminder, the workgroup would like ACIP's feedback on. The QPP schedule stands for 1 quadrivalent dose at 11 and 12 years, 1 pentavalent dose at 16 years, and another pentavalent dose 6 months later. The strengths of this schedule include reducing the number of doses from 4 to 3, a small cost savings per person. The proposal is relatively straightforward. It potentially allows stocking of 2 vaccines for most patients, and it matches the dosing used in the clinical trials. Weaknesses include the fact that persons needing 3 doses of MinB would still need Trememba, Pfizer's MinB FHBP vaccine, because of the 6-month interval between doses. There's less cost savings than the QPB, the workgroup's proposed option. There's a higher cost per quality saved compared to the standard of care. And there are concerns from the workgroup that this option could lead to MinB vaccine being discontinued, but it's worth noting that the need for Trememba for some of the doses for people at increased risk due to underlying health conditions might reduce the likelihood that this would occur. And as we just heard from Pfizer, that's not their intention. Finally, here's a head-to-head comparison of the 2 options using a few of the key criteria. Both options would reduce the number of doses from 4 to 3. There's a cost savings for both options compared to the standard of care, but QPB saves about $50 more per person. The cost per quality saved is less than the standard of care, but for QPB, but not for QPP. QPP only requires 2 vaccine types for the routine schedule, while QPB requires 3. Both options need 3 vaccine types for the increased risk schedule. QPP matches the dosing schedule used in the clinical trials, but QPB does not. Finally, QPP gives an additional dose of MinACWY than what is needed, but QPB does not give any additional doses. So with that, we're now at the end, and I'd like to thank the people listed here for their efforts in making this presentation possible, and thank you, ACIP members, for listening and for any feedback or suggestions you have to aid the workgroup members in the next steps of this assessment.
Thank you so much, Dr. Crow. And we were just saying how amazing a presentation that was, because that was extremely complicated, yet somehow you made the recommendations seem fairly simple for us to consider. So thank you for doing that, and thank you to the work group for somehow making that happen. I don't know how you did that. Well, we have a bunch of questions. Let's start with Dr. Daly.
2 quick clarifying questions. One is, what is the current coverage rate for MinB in the United States?
So for a single dose, it's 31%, and we recently learned from our NIS teens colleagues, and this will be published, I think, in the coming months, that the second dose is a little less than 12%.
Thank you. And then on a completely different topic, total number of cases of invasive meningococcal disease, ages 11 through 15. Thank you. Per year in the U.S.
So I don't have that off the top of my head, but maybe my Dr. McNamara does.
The total number of cases from 11 to 25 is approximately more than 400 cases, corresponding to the serogroups A, B, C, W, Y.
Could you go to slide 10? That might also just help. It's, incidence rates, but. Could you go to slide 10?
I'm sorry, Dr. Lee, I didn't hear you. Sorry, slide 10.
Sorry, while Dr. Crow is pulling that up, this is Dr. McNamara. I just wanted to highlight the numbers that Dr. Ortega-Sanchez just provided are from the pre-vaccine era. Currently in the United States, or rather pre-COVID, we had about 350 total meningococcal disease cases each year. Those numbers dipped sharply during COVID. They do seem to be rebounding now. I was just pulling up our most recent surveillance reports, but yes, I think this graph shows clearly that there are very few residual cases at this point in the 11 to 15-year age group.
This is incident.
It is incidents, and so I do want to remind everybody that we did not have the EPI post-COVID and wanted the EPI post-COVID before diving into other questions. So we had a very narrow focus intentionally.
And just to add, because I did pull up our 2019 surveillance report, which might be most useful given the dip during COVID, but we had 9 cases in the 11 to 15-year age group in that year.
For BACWI total?
Correct, that's total.
I understand. Oh, go ahead, Dr. Lair.
So I'm on the work group, and I sort of wanted to give a perspective and a summary. I think we all agree that if you feel that the B is appropriate from shared clinical decision-making, giving the pentavalent when they need both the ACWY and B is reasonable, cost-effective, and great. And that, at the beginning, was as far as I wanted to go. And then I had lots of people on the work group say, you're risking offices just stocking P, the pentavalent. And I was like, why would they do that? But they said that might happen. And then we said, okay, well then we should study, do we want to give pentavalent at 11? Do we want to give a pentavalent as the second one? And that's where all this complication is coming from. And I think we've come to some decisions, and I have my own perspective on it, but that's why this is all here. It's a good combination vaccine. It's safe. It's just as effective as the 2 separate vaccines. I personally believe that they are pushing the envelope by asking us to expand the recommendation to give B or ACWY in situations where we weren't previously recommending it. But that's my personal belief. Thank you.
Dr. Long?
Is the ACWY that's in pentavalent identical to the quadrivalent that we use? And is the immunogenicity and expected protection after a single dose identical to what we have?
No.
Thanks, Dr. Long. So the vaccine is the Memerix. It's not licensed in the U.S., but the work group did look at the data from Europe and found it to be both safe and efficacious, or the immunogenicity being similar in terms of what we see here in the U.S. Pfizer did compare their vaccine to Menveo, which is a product that's currently available in the United States, and it did perform well. It's not inferior.
So the second dose in the trial at 6 months was for the B alone component? Was probably for the, I know it wasn't the B alone given, but if, we're happy with 5 years after ACWY, then, and you think it's similar, then then the second dose that's indicated for pentavalent would really be for B only. Because of B, not for B.
And it would be B from Pfizer or Trumbemba in particular, yes.
Dr. Brooks?
Yes, I guess going with what Dr. Lair said, is there any benefit in getting a single dose of B at 16? In other words, exactly, because, theoretically, if someone only needed ACWY, you would give 2 QQs and you'd be done. But if I gave a Q and then a Penta, would that B that they quote-unquote didn't need still offer some protection against B, which they theoretically didn't need anyway, but maybe they did need? You see what I'm saying? What does a single dose of B do for you if you got that additionally at 16?
Thank you for the question. So the protection is substantially lower. It is a 2-dose recommended series to gain the protection that you would need in order to have a full series completion. So.
Yeah, but I bet in the studies for B, they had some data on a single dose, even though it's obviously indicated for 2 doses.
So Pfizer is looking at extended interval data. We are waiting for those data to be available. They won't be available prior to your vote in October or licensure, however, but we are anticipating some data soon. Dr. McNamara.
Yeah, I'll just chime in to say, that there's not vaccine effectiveness data for the serogroup B vaccines in the United States, but based on the immunogenicity data, the immunogenicity after only a single dose does seem to be very low. We would expect low effectiveness. And there are data in infants from other countries that support the fact that there's much less effectiveness after a single dose.
And thank you. That answers the question.
And I think we should also highlight that B wanes relatively rapidly even after 2 doses. And that's immunogenicity.
And speaking as someone who vaccinates these children, I've had many people come to me and say, I'm not sure I want to give B at 16 and 16 and a half because the highest risk is when they're going off to college, which is usually around 18. And they're worried that if they give it at 16 and 16 and a half and it wanes in 2 years, that they're not protected when they go off to college. So personally, if I were to do this, I would not be giving the B at 16 and a half. I'd be giving the second B this summer before they go off to college. But that's, again, a personal clinical decision.
And I would add, for the children that I've cared for my whole career, those who don't go to college are as at risk, if not more, than those who do go to college. So, we have to think about them as well.
So, well, let me just say that for the proposed wording of the recommendation that was given, I do think that's a reasonable proposed wording and it's very clean. But I'm going to ask the question that I'm sure the work group has talked about in some way, shape, or form, which is, have we thought about rethinking the schedule entirely and whether or not we should just do 2 doses, and to your point, between 16 and 18? Because that seemed, and the nice thing about that is it's reflecting sort of the revised epidemiology. So looking at that over 12 years, it doesn't look like the highest risk kids are 11 to 15.
There is tremendous interest in doing that. And the feeling is we need the epidemiology post-COVID to guide that discussion. And so anyway, it is on the table and is of interest.
I guess I might say that we might be waiting for several years for that epidemiology to settle. So I don't know if that would influence my decision-making about making this recommendation, given you have 12 years of data.
Okay.
That would be my opinion.
We just didn't want to take everything. We needed to divide the work that the work group needed to do in sections. And so this was the first section we wanted to do, but that has been actively discussed and is of great interest to many. Thank you.
Dr. Sanchez?
Grace, I just wanted to agree with you and just support that, and I've brought that up before. I agree. I don't see the reason to give the 11 to 12-year-old meningococcal vaccine.
Dr. Long?
Back to the wording of the proposed ideas, I think that the other part that would be important is that the family would have to decide at the time of the second dose of ACWY that they were going to pursue B. Because if they weren't, it would be cheaper to give them ACWY one more time and be done.
That is correct.
So they would need to have that discussion, and that would be a little more complicated for the practitioner to have now that there's one that has them all. They, this idea, this is a meningitis vaccine, get it all done, is there will be lost in that all the things that you said that were very clear with the small outbreaks of B, that the vaccines, after everything is said and done, were not highly effective, were effective for a short period of time, and were not effective after a single dose for very long. The other thing that I just want to wonder a little bit about in the timing of looking at this again, when I look at the graphs of how meningococcal disease rose many, many decades ago and then fell, more prominent in the military, a CDC, great, wonderful study about bar patronage. Remember, bar patronage and risk of meningococcal disease was the title. And in Atlanta here, it was a significant risk. And it's thought that smoking increases the vulnerability of the respiratory mucosa to colonization by all kinds of things, including meningococcus. And if I sort of look at the epidemiology of meningococcal disease in the United States and meningococcal disease in countries in Europe where they have not done anything about smoking, ours has gone way down associated with banning smoking in public places. And I just worry a little bit, having seen a few teenagers with severe hypersensitivity kind of pneumonia from vaping, that it is possible that it might increase again in that age group. I don't think the 85-year-olds are vaping, Dr. Talbot. We wouldn't know which end to put of the cigarette. Which end of the cigarette? That is it.
Dr. Deschamps?
Yeah, hi, this is Dana Deschamps, representing NAPNAP, the National Association of Pediatric Nurse Practitioners. My question would be, when we are making the recommendation, and currently with the MINB, it's the shared clinical decision-making, whether if we go forward with some of those options, whether that then should be a stronger recommendation. And looking at the graph, most of those cases of those MINB were those 16 to 20-year-olds. I mean, I practice in a pediatric office as well. And I mean, we capture those 16-year-olds because they're coming in before their senior year. In my state of Illinois, they have to have that ACWY vaccine. But I do still have parents that are hesitant with just doing the MINB for what's already been mentioned with that. And also, I just want to put forth, there are certain organizations that they have contracts with other specific drug companies, GSK versus Pfizer. And so that would impact also the availability of getting those vaccines as well. Thank you.
Thank you. Well, a couple things. Maybe a possible request, and I'm looking at Dr. Ortega just to say, is it possible to consider modeling out QQ 16 to 18, PP 16 to 18, and then Q plus B 16? I mean, to me, that would be what I would be interested in looking at. And the reason I bring that up is partly because I understand that the vaccine is not yet licensed for use, and so we're making our best estimate on the cost in the model, but it's very influential. It's already, let's just say it's not cost effective. So and it's going to be even less cost effective, but this is all dependent on the approach that's taken. I do think the idea of taking it down from 4 to 2 doses is really appealing to me for multiple reasons, just because I think we should be reconsidering our schedule and streamlining whenever we think it's possible, as long as we're optimizing protection for that child or that individual. And when we can reduce the number of exposures and maintain a high level of protection, it seems a reasonable thing to do. But the thing that stands out in my mind is it's not cost effective, as Dr. Long mentioned. And so it has a huge impact. And part of the reason I believe around shared clinical decision making for that was because of the cost effectiveness. And to Dr. Lair's point, I do think we have to acknowledge that the durability of immunity of serogroup B is likely not there. And I do feel a lot of parents and teens maybe want to optimize their protection right before they head off to whatever congregate setting they may be heading off to.
Yes, definitely. Yeah, and definitely we can consider the vaccination. It will be at 15 to 16 with 2 doses of pentavalent versus quadrivalent, or the option of thinking, for example, BV as well. So it can be modeled and see how it will impact. Yeah.
Thank you. Dr. Litter, do you still have your card up? No? Okay. Any other questions, comments? Thank you so much. Oh.
I just want to say thank you. This conversation is very helpful as we move forward.
Thank you so much. And with that, we will take a break. I'm going to give us till noon. We'll do our best to catch up, but there's no actual lunch break, so I'm going to give us like 13 minutes to run and grab lunch, and then we'll come back. Thank you.